All right. Well, good morning, everybody. It's a beautiful morning, kind of, but it's kind of rainy. We need some rain for the green. I appreciate everybody coming here on the early Monday morning to talk about aortitis. First, I would like to thank you and thank also Johnson & Johnson and Amgen for supporting this program. So I thought about a topic, and a lot of topics in the vascular arena, and I think one of that we scratch our heads a lot, my vascular surgery colleagues and myself, is aortitis, because we see a lot of patients with aortitis more than usual these days, and we kind of think a lot about the underlying etiology, and after we make the diagnosis, we tend to think a lot about whether the disease is active or not, and after which, what we're going to do with these patients. So that's what the topic is about. There are some disclosures not insignificantly related to this topic. So the objectives of this talk is to discuss different etiologies and differential diagnosis of aortitis. We're going to share multiple cases, most of which are from my own practice. And we're going to show how these patients present very similarly with similar also blood work and imaging findings, but definitely they have different etiologies and different management. And we're going to share some kind of thoughts about how the diagnosis could be very challenging. And we're going to also discuss some of our published experience, and we're going to finish up with some of our recommendations. What is aortitis? It's a rare disease with different underlying pathogenesis. If you think about inflammation, it could be infectious, could be malignant or idiopathic. A lot of times we try and we do our best to find an underlying etiology, and then we kind of call it idiopathic because we couldn't nail it down. As I mentioned earlier, diagnosis and differential diagnosis could be very challenging. It requires multidisciplinary approach, which we have here in MHI. We have vascular surgeons, vascular medicine, cardiologists, rheumatologists. This is great collaboration to make the right diagnosis. And because these diseases, they present very similarly, to the point some scholars believe that aortitis is just one disease with different spectrum. Management is based on the underlying etiology. As I said, it's important to consider a multidisciplinary approach. I love it when we see a case on our floors with the aortitis, and I kind of sit in front of my colleagues and say, this is this, and says, no, this is this, right? So we're looking at the same thing, but we both look at the disease from different perspectives. So if we start talking about inflammatory aortitis, the prototypes of inflammatory aortitis, we think about giant cell arteritis. In the past, we call that temporal arteritis, Takayasu arteritis, which is very rare, or IgG4 disease. We have seen a couple of cases in our practice. And periaortitis. In the past, we used to call this retroperitoneal fibrosis. The new terminology now is periaortitis. And we'll go over that in details. Inflammatory aortitis could be secondary to other diseases. If you think about other types of vasculitis, Cogan, people also have hearing loss in this disease. Behçet disease, which was described in Turkey. Kawasaki, I have shared a few cases with the cardiology, with a practice. Patients came down with coronary aneurysms and aortic aneurysms, and they turned to have Kawasaki. Other autoimmune diseases and connective tissue disorders like rheumatoid arthritis, lupus, relapsing perichondritis, sarcoidosis, and so forth. And also patients with rare disease, which is non-Langerhans histiocytosis. We call that Erdheim-Chester disease. We have patients that we diagnosed with radiation-related aortitis. She was treated as well. And again, sometimes we do all the workup and we can't nail it down to a specific etiology. We call it idiopathic inflammatory aortitis. Infectious aortitis, which are also rare, but could be disastrous, unfortunately, because they're very complicated, very hard to differentiate from the inflammatory aortitis. Could be bacterial, most of which could be caused by staphylococci. We had a case actually with salmonella in our practice. He came back and forth for different indications. Viral herpes, varicella hepatitis has been really reported to cause aortitis. Fungi, as you can see there, can cause that too. Malignancy, from primary malignancy like histiocytoma, angiosarcoma, sarcoma, or it could be paraneoplastic. We have diagnosed a few patients with lymphoma-related aortitis in our practice. So now we're going to go over 8 cases, and I'm going to, through these cases, we're going to see how diagnosis could be challenging. And it's good kind of practice to see how we work up these patients and how the treatment is, and we'll go from there. Case 1, so 52-year-old female with history of shoulder and hips pain. She presented with abdominal pain, fever, chills, and night sweats. And I'm going to want you to notice how the presentation of all these 8 cases are very similar, and even the workup results are very similar. Vital signs were kind of normal, but she had a paraumbilical abdominal tenderness, and she also has shoulder pain, shoulder and hip tenderness. Workup showed leukocytosis, significantly elevated ESR and CRP. The rest of workup was negative. This is a CT angiographic image, transverse image of this patient. And what it actually shows, you could see the abdominal aorta, significant wall thickening, measuring about 7 millimeter. By the way, up to 3 millimeter of a wall thickness in aorta could be considered normal. 4 and above, it's considered to be abnormal. So this patient has significantly thickened abdominal aortic wall based on the CT angiogram here. So she's a female, she's above age of 50. She has shoulder and hips pain chronically. That's polymyalgia rheumatica. And this is how we made the diagnosis for giant cell arteritis. She meets the criteria. And the main treatment for GCA is prednisone, 40 milligram, and for 2 to 4 weeks, and after that we start slow taper. For her, her symptoms improved significantly within 3 weeks. So did her ESR and CRP in 4 weeks. And if you look at the images, the CT angiographic image after 6 months, significant improvement of her aortic wall thickness. So this is how we make a difference for diagnosis and follow-up as vascular specialists, because if these patients just follow up with a rheumatologist, the rheumatologist does not really get involved too much with reading images. So it's very important to be part of this multidisciplinary management of these patients with GCAs and other types of vasculitis. So what is giant cell arteritis? It's a granulomatous large visceral vasculitis, mostly affecting females 50 years and above. There are 2 types, large vessel and cranial GCA. Cranial is, in the past, we used to call it temporal arteritis. We don't use that term any longer. So if it's cranial, it's temporal arteritis, means cranial, or large vessels. It could be like the major vessels as well as the aortic involvement. And these are the criteria that the American College of Rheumatology uses to make the diagnosis for GCA. You can see that we need to have 3 and above of these criteria, and our patient had met all these, most of these criteria. And now we use more, the most kind of recent update from American College of Rheumatology just 2 weeks ago, they actually focus on the ultrasound as one of the first and main imaging modality to make the diagnosis of GCA. And now actually in our lab, now we consider to be a referral site to help make the diagnosis for GCA. We look into the carotid, we look at the axillary, subclavian, and then temporal artery thickness and velocities, and we have our own criteria to nail down diagnosis. And sometimes, if we still have issues with that, we consider biopsy, and that's where the patients make it to my vascular surgery colleagues as well too. So we talked about the 2 types, large vessel versus cranial. So, for patients with giant cell arteritis, mostly affecting the large vessels versus just the temporal artery, they are usually younger. They present younger in age, and there is a delay in diagnosis. Usually, it takes kind of up to 8 months to make the diagnosis because they don't have the typical presentation, jaw claudication, headache, eye problem, because this is not cranial. It's mostly large vessel involvement. And also, they have less cranial involvement, as I said, less visual disturbance. Usually, the biopsy is negative in most of the time, and they are less likely to meet the criteria for the American College of Rheumatology. So how do we determine disease activity? It's an actually state of art because you have to look at different factors. You have to look at the patient, how they're doing, how their symptoms are. You have to look at their images. You have to look at their labs too, and you have to really make the kind of the decision whether disease is inactive or not, so you can make the right choice for the treatment. And we all talk about elevated ESR and CRP, although we use it all the time, but it could be tricky because there are a lot of times patients can have an active disease, but yet normal ESR and CRP. And sometimes ESR and CRP could be elevated, but the patient does not have active disease. So that's why I said it's state of the art. You have to take all these considerations together to decide about the activity of the disease. And a lot of time we get PET scan, but I have to say that PET scan, it could be positive in many other conditions. Post-op, if Dr. Manunga, let's say, takes care of a patient with aortic aneurysm, we get a PET scan after that, it's going to be positive a little bit for a while. Patients with atherosclerotic disease, infection, so the specificity is not that great, it's 41%. But now there are more research about more specific ligands to kind of nail it down to the inflammatory types. And we have the FDG PET scan now, and that actually brings up the specificity to up to 97% for diagnosis and follow-up. So how do we manage patients with GCA? The main treatment is steroids for GCA. We usually start 40 to 60 milligram for the first 2 to 4 weeks, and carefully we start taper down the prednisone as you see from the slide. So we start by 5 milligram every 2 weeks, and then till they down to 20 milligram, and I bring them back usually with repeat images, lab work. And after that, if they're doing well, I keep the taper at 2.5 milligram every 2 weeks until they are down to 10 milligram, and slowly we do the taper. Why we take this very carefully? Because the recurrent risk is pretty high in patients with GC, as we're going to see in the coming slides. It's not really fun to prescribe steroids to elders because GCA usually they are older people. I have a lot of stories to share, but I'm not going to share all of them because they could be embarrassing. 2 elders coming, a spouse on prednisone, like 40, 60, they are 80 years of age, and the husband or wife sitting in the room, oh, please take my spouse off the prednisone, they're being crazy, So that's why I think it's important to think about a steroid-sparing agent, and tocilizumab, or Actimra, in other words, it's an interleukin-6 inhibitor. That's the only drug that's FDA approved to treat GCA and help to spare these patients the side effects of steroids. Based on a study, actually that included patients with GCA, they were given tocilizumab or usual care, which is steroids. The tocilizumab arm, in addition to prednisone, showed significant reduction of the required dose for glucocorticoids, and also decreased the rate of first relapse as well too. So nowadays we consider actually tocilizumab in patients with GCA, especially in patients that do not respond to initial prednisone trial. And the good news is that we can get these patients off steroids within 3 to 4 months rather than a year without tocilizumab. So the problem that the initial study showed that effectiveness for tocilizumab in the first year, and then what happens after that? So newer information showed that if you stop after a year, there is actually increased risk of recurrence up to 40%. So nowadays, there is kind of one recommendation from an Italian group that after the first year of Actimra or tocilizumab, we try to do it every 2 weeks rather than every week for another year, and then that reduces risk of recurrence. There are other medications that are available in the market, but the one that showed promising result is the stinkinumab, interleukin 12 and 23 inhibitor. We don't use it much in our practice. The main that I use is subcutaneous tocilizumab every week for a year, and then I taper that down as well. For surgeons in the room, so what kind of experience do we have with GCA-related complications? Based on this paper, looking at 40 patients with GCA that required surgical intervention for either aneurysms or dissection. especially mainly thoracic involvement in 40 patients. About 22% of these patients had PMR and temporal artery involvement. And as I said, these patients had presented with inflammatory aneurysms or acute dissections, especially 4 of them had emergent repair for acute dissection. 85% had an arch replacement. 13 patients had elevated ESR and CRP. And they actually had good post-operative complication kind of profile. Just 2.5% had wound infection. Like other thoracic surgery, there's AFib that was 40% of the time. Stroke risk, 2.5%. Freedom of intervention was almost kind of 90%. And most kind of the predicting factors for reintervention is elevated markers, ESR and CRP. That's why I kind of work closely with my vascular surgery colleagues to ensure that the disease is inactive before they go and operate in these patients, because we know for sure that the recurrent risk is high or complications are high in patients with active disease. And 5-year overall survival is 91%. Prognostic or prognosis and relapse. Relapse can happen up to 74%, which is kind of a lot. And late relapse has been kind of described. 50% was still on treatment in 5 years. Up to 75% of these patients would be off steroids in 5 years. Survival is actually similar to general population. Aneurysms are indicators for high mortality. And also, large vessel-related complications can occur years after. I have actually diagnosed a patient with inflammatory thoracic aortic aneurysm 5 years after she had been treated for GCA. So now we covered GCA. So the next case we're going to talk about is a different case, 42-year-old female. She's actually a surgical tech that worked in our OR. She presented with 1 month of malaise and hips, bilateral hip pain, buttock pain with walking. She also had the left foot pain with purple discoloration. Vital signs, she's tachycardic. She had the left purple and cold foot. She has non-palpable pulses. CBC and CMP normal. Again, elevated ESR and CRP. Here, bilateral ABI shows moderately reduced ABI at 0.71 with monophasic waveform throughout. That tells you there is some kind of inflow disease. The rest of autoimmune workup and blood cultures were negative. This is a CT angiographic images, transverse image of the abdomen and pelvis, showing significant aortic wall thickening. It's almost kind of subtotal occlusion almost. Wall thickening, significant wall thickening in the abdominal aorta. Look at the bifurcation for the common iliac arteries. Trickle flow through the bifurcation and common iliac arteries. So this is significant inflammation or wall thickening, I would call first, in this patient. This is a coronal view of the same patient showing significant aortic wall thickening that actually extends to the common iliac arteries. So what is the diagnosis in this patient? She's a younger female. She has significant wall thickening on the aorta and major vessels. So we diagnosed her with type 4. And we'll talk about the subclasses of Takayasu aortitis. And we diagnosed her with Takayasu based on her age, gender, and severe stenosis and involvement of her disease. So we managed her with prednisone, aspirin, and statin, walking program because she had active disease, and the questions from the surgeons and the recommendation would to wait until her disease is actually under control. But she came back in 3 weeks, and she came down with sudden onset left leg pain now, cold foot, non-palpable pulses. So now the question, is this acute critical limb ischemia? So we started her on IV heparin. And if you notice, actually, although the wall thickening, maybe it's better, but look what happened to her. So the left common iliac artery now is completely thrombosed right there. So that's what kind of led to her current presentation. This is the coronal view, again showing the left common iliac artery is down now. And then we know that Takayasu aortitis can cause increased risk of thromboembolic event what happened in this patient. So what the treatment was is catheter-directed lytic therapy and aspiration thrombectomy with significant improvement. But the procedure was complicated by right common iliac artery dissection. If you ask me why, because we had to intervene on this patient while she has active disease. And that's kind of increased risk of dissection because these vessels could be very fragile when the disease is active. And then we put her back on prednisone, Lipitor, aspirin, and warfarin because of thromboembolic event. And actually, she came back 2 months later with normalized markers. Her inflammation continues to improve, as you see from the CT angiographic images. Now, the bifurcation, bilateral common iliac arteries are patent. Inflammation continues to improve. This is a coronal view of this patient showing really now patent left common iliac artery, and then patent stent on the right side that had to be placed because of that complication with dissection. So what is Takayasu aortitis? It's a rare chronic large vessel vasculitis, mostly affecting the aorta and large vessels, and mostly affecting females younger than 40 years of age. As you see there, it's kind of more prevalent in females. And we don't get to see a lot in the United States here. It's more prevalent in Far East countries like Japan. So we see 1 to 3 cases in the States like in a million. Actually, in my practice, I have at least 20, 25 patients with Takayasu. They come from across the States here. And actually, we see a lot of them are from Somalia, although Somalia is not listed here. I have at least 6, 7 patients, Somali patients with Takayasu aortitis. And so the presentation, they usually present with systemic complaints, as you see, but with the disease progression, with the stenosis, you see end organ kind of ischemia, you see poor pulses, blood pressure discrepancies. Some people call it pulseless disease. And if you wait so long, patients can develop aneurysms, pulmonary hypertension, arterial rupture, and thrombosis. Although we talk about most of the cases are younger than age of 40, so the Japanese have actually published their experience with Takayasu that presented or was diagnosed at age of above 40. So based on a registry that had 1,300 patients, about 43% of these patients were diagnosed older than 40, age of 40. And those patients, usually the diagnosis could be delayed. They have more dyslipidemia, hypertension, less carotid involvement is 60 versus 90%. That means that they have more carotid involvement, more coronary involvement, especially in females. And we have had patients with Takayasu that presented to our institution here with acute coronary syndrome that I had to share the cases with the cardiologist. So the diagnosis is based on the clinical presentation as well as lab and images. And then again, we look at the ESR and CRP elevation. There's some data on interleukin-6 levels as well too. But again, you have to take things in perspective and look at the picture in general. Labs, you look at the patient, you look at their images and make the diagnosis. PET scan can be useful, but again, you have to be aware of false positive results in these cases. So there are 5 different types of Takayasus that have been reported in the literature based on the involvement. You could look at the involvement and the type. The most common type that we have in the States here that we see is type 5, although it's actually type 1 in other countries. I have seen quite a few type 5s here in our institution. We had seen also type 1 for the most part. Type 4 is just the abdominal involvement, and that's the one that we just presented, the case that we just presented. So we do have data that Takayasu not only causes inflammation in the arterial wall, predisposing these patients for arterial thromboembolism, but we also know that it actually activates the platelet in a bad way, so patients could be really highly thrombotic. And that's what happened in our patient. She thrombosed her left common iliac artery. We searched the literature actually, and we couldn't find any other case with iliac artery involvement as we published this case with our research intern. By the way, we're looking forward to having our interns arriving this week because they've been generators. They've been writing a lot of papers, so I'm very excited to work with them. So how do we manage Takayasu? Slightly similar. We start with prednisone, 40 to 60 milligram, and we start slow taper like we discussed earlier. But there is more data rather than with interleukin-6 inhibitor. We have more data on anti-TNF agents like etanercept, which is Enbrel, adalimumab with Humira, or infliximab, Remicade. So we use these, especially we use Humira in these patients, and they've been really good outcome in these patients. For interleukin-6 inhibitor tocilizumab, the data is kind of low. There is data, but the number of patients is low, but it's still listed as an option as a steroid-sparing agent. DMARS, like methotrexate, is also effective, so we've been using that for the long-term control of these patients. So for patients that require surgical revascularization, open versus endo, looking at the case series and patency at almost 10 years is for open is up to 80%, and for endo is 52%. This paper is a little bit older, and now there's more data to support also the consideration of endo treatment. We just had a recent case as a Somali patient that presented very similarly to this patient, and he had claudication, he had significant involvement in the iliac. Dr. Manunga actually operated in this patient and placed a stent graft, and the patient did great after we controlled the disease, and after endovascular approach, his symptoms completely resolved, and he's doing great. Thank you, Dr. Manunga, for taking care of that patient. He's doing great still. And then how about disease activity and outcomes? Because we talked about, we should really hold intervening on these patients until their disease is under control. We always try, right? But sometimes they present acutely, so you have to operate on them early on. So based on this kind of case series, looking at patients, 251 patients with Takayasu, 42 out of these patients, 17% required operation. And the outcome were really good, not a whole lot of significant increase in mortality, MI, a major stroke in these patients. And then 31% of these patients actually required revision, especially if they have elevated markers. So this is kind of showing that if the patient is off prednisone versus on prednisone, it's a sign like being on prednisone that you're actually getting treatment for your active disease. That showed patients who were not on prednisone had more kind of need for revision, and so patients with active disease versus inactive disease. So we really try to make sure that the disease is under control or inactive before our surgeons operate on these patients. Prognosis, 5-year survival, slightly reduced, like it's different from GCA, patients live normal life, but patients with Takayasu's, especially if they have active disease and complications, they have really worse prognosis. If you have active disease or complications, your 15-year survival is 66 versus 96 if you don't have complications. For patients that requiring surgical intervention, based on another paper, survival at hospital is almost 90%. Overall survival in 20 years is 74%. Sometimes these patients develop like anastomotic aneurysms in about 14% of the patients. So basically, the surgical outcome could be really good, especially in centers where there is a good expertise, surgical expertise, and especially if the surgeons operate in these patients while they are inactive. So case 3 now, we're going to shift gears. We're going to present the third case that kind of almost presented similarly to the other 2 cases, but the patient will have completely different diagnosis and needed different treatment. 51-year-old male presented with 2 weeks fever, night sweats, and chest pain. He has friction rub, erythematous rash. He has leukocytosis, elevated ESR, and CRP. And then normal troponin, chest X-ray, cardiomegaly. He has atrial flutter. Echo shows significant reduction of ejection fraction, moderate pericardial effusion. Sounds like this guy has a systemic presentation. and his aorta was enlarged. So this is a CT angiographic transverse image of this patient showing significant enlargement of the ascending aorta with significant wall thickening. Is actually his aorta measured 6.5 or 65 millimeter. And then so you see that wall thickening is significant. And then you see also that the aortic arch is involved, significant wall thickening involving the aortic arch. And again, diameter of the largest diameter of the ascending aorta was 6.5. And then so although the cardiac surgeons said, well, 6.5, this is kind of might need intervention, repair. But again, this patient is presenting with unknown cause, and there's an active disease. So you don't want to jump right away and operate in these patients. And then the CT angiogram also reveals significant wall thickening involving the abdominal aorta right here. So there's something going on. There's a systemic disease involving the thoracic and abdominal aorta. And then if you look at the labs, more confusing. His A&E is positive. His CNK is strongly positive. Rheumatoid factor is also positive. So risks of rheumatological workup, including IgG4, were negative. Chest CT also showed mediastinal lymphadenopathy. PET scan showed increased uptake in these areas where the aorta was involved. So you get all this kind of presentation. And then so his cultures were negative. Of course, you have to rule out infection before you want to consider like a treatment for an autoimmune disease. His skin biopsy where he had rash, sometimes we really use the biopsy to try to nail down the diagnosis. Unfortunately, it was non-specific, but there was some inflammatory infiltrates in the sample. So differential diagnosis, is it GCA or ANCA-related vasculitis? I have to say ANCA-related vasculitis or ANCA-associated vasculitis usually affects the small vessels, not necessarily the aorta. There are only 5 to 6 cases reported in the whole literature, actually, with ANCA-related associated vasculitis. Is it rheumatoid arthritis? So what we did, actually, we started the patient on high-dose steroids and methotrexate, and then he didn't respond, so we had to consider tocilizumab, thinking it might be related to GCA, but he didn't respond really well until we thought about using rituximab, because remember his C-ANCA was positive. So actually the diagnosis of this patient was C-ANCA-associated vasculitis, which is really, it was the case number 6 in literature that presented with aortic involvement, and we published this case as well. So he was treated with rituximab, tapered down prednisone, and he had his surgery done. Look at the improvement of the aortic wall thickness there and the thoracic and the abdomen. So yes, it was C-ANCA-related vasculitis or ANCA-associated vasculitis, which is granulomatous disease. There are different types with C versus P-ANCA, as you see there. So the main type with positive PR3 ANCA is granulomatosis with polyangiitis that really affects the aorta. There is the American College of Rheumatology criteria that you can see there that we use to make the diagnosis. So my management is actually for this type of group of diseases is to use glucocorticoid combined with rituximab. We used to use cyclophosphamide previously, but now there is more indication to use rituximab due to side effects. So this is case 3. Now we're going to shift gears and talk about a completely different case that has similar presentation. So this is a 70-year-old male that came with hypertension, with history of hypertension and diabetes, presented with left neck mass. It was kind of painful, right eyelid swelling, night sweats, and abdominal pain again. Okay, so systemic complaint, but there is kind of a hint here. He's got a submandibular swelling and right eye swollen. If I had time, I would pick up on our fellows, but I don't have time now, so I'll just keep going. So physical exams, there is actually a submandibular tender mass on the left side, abdominal tenderness. If you notice the labs here, I have to kind of help you to make the diagnosis right away. So leukocytosis, there is some sort of hepatitis, L15, and look at the lipase, so there's pancreatitis, so that's kind of giving away the diagnosis. And there's inflammatory markers that are elevated. Chest X-ray showed lymphadenopathy. Abdominal CT showed pancreatitis with sausage-shaped pancreas. And then the rest of the autoimmune workup is negative. So this is the CT again. All the CTs looked very similar, as you can see. Transverse on the left and corona on the right, showing significant abdominal aortic wall thickening right here. And this is kind of a very typical for retroperitoneal fibrosis or periaortitis, the new terminology. So look at that. It's kind of encases the inflammation, encases the whole aorta right there. Anybody knows what diagnosis is? IgG4 disease, okay? Because this is a systemic disease. So the biopsy of that left mandibular mass showed lymphoplasmacytic infiltrate. That's kind of the main finding, plus phlebitis and fibrosis. That's kind of the periaortitis finding, so retroperitoneal fibrosis. And IgG4 disease actually is a systemic disease that share particular pathologic and serologic and clinical features. What are these features? Tumor-like swelling involves organs, lymphoplasmacytic infiltrates, and that's staying positive for IgG4. There's variable findings that kind of support the finding of fibrosis, elevated serum IgG4. I just don't want you to think that all cases will have serum IgG4 elevation. You have to find that in the tissue, not necessarily in the plasma, because 60 to 70% only of these cases had elevated levels in the plasma. What are these major presentations? Salivary gland disease, orbital, like this patient had lacrimal gland inflammation, and retroperitoneal disease, including periaortitis, pancreatitis, like this patient, cholangitis, sometimes hepatitis, and there's also thyroid and renal and lung CNS involvement. So how do we treat these patients, or how do we diagnose them first? And diagnosis is based on the clinical classic organ involvement and serology, showing IgG4 presence. Radiology, looking at periaortitis, sausage-shaped pancreas, and the pathology staining positive for IgG4. And the treatment, we start with prednisone, and again, rituximab is a good agent for these patients. So now case 5, a 55-year-old male has history of hypertension, presents with abdominal pain and left flank pain that radiates to the groin. Again, another patient comes with abdominal pain. And then the physical exam, periumbilical, left flank, moderate tenderness. So leukocytosis, creatinine, look at the creatinine. That's kind of, again, a hint to make the diagnosis. 3.2, so the patient is coming with acute renal failure, left flank pain. ESR and CRP are significantly elevated. The ultrasound showed hydronephrosis on the left side where he had the pain, and the rest of workup came back negative. And then they look at the CT, again, similar presentation, significant abdominal aortic wall thickening. And if the patient underwent biopsy that showed both fibrosis and inflammatory markers, positive, or inflammatory cells infiltrates in this sample. And the diagnosis is periaortitis, because the patient has that ureter obstruction with that retroperitoneal fibrosis. So what is periaortitis or retroperitoneal fibrosis? It's a rare condition. You have to have a combination of inflammation and fibrosis in the retroperitoneal space that actually that inflammation encases the ureter and other abdominal organs. It could be just a primary by itself, or it could be secondary to IgG4, like we did see in the previous case, or other autoimmune disease, or even lymphoma. Diagnosis is based on the clinical lab and biopsy, a treatment with prednisone, methotrexate, tocilizumab, and rituximab. 3 more cases to go on. I know we're kind of going fast, but I'm trying to cover as much as we can. A 50-year-old female, this case is actually from my colleague at Mayo, Dr. Koster. He's a rheumatologist that I did actually my fellowship. He was doing his fellowship there when I was there. He shared this case with me. 51-year-old female presents with chronic legs and periumbilical abdominal pain. Now the hint is the legs pain, so let's kind of find out what she has. She has normal CBC, but again, elevated ESR and CRP. X-ray showed symmetric osteosclerosis, or diaphysis of the long bones. That's where it's going to help us to make the diagnosis. And again, CT angiogram is all kind of very similar. You see that The aorta is really kind of thickened, the wall there. And what also you could see, look at the kidneys. There is like almost like a coat, or there's like a significant thickness of the tissue there on the kidneys on both sides. So what is the disease? It's the Erdheim-Chester disease, which is really a very rare systemic disease caused by infiltration of non-Langerhans cell histiocytosis. It actually leads to periadventitial infiltrates. It could mimic IgG4 Takayasu Aortitis. And 50% of these patients, they have BRAF V600E gene mutation. Workup is actually by proving non-Langerhans histiocytosis with a biopsy. You could test for the gene mutation. Patients will have elevated ESR and CRP, and the images will show hairy kidney. That's the coat kind of almost that we found around the aorta and around the kidney. And the treatment is based on if the patients have gene mutation or not. And you can see the treatment. It's a very rare disease. I have not encountered any case in my practice. And it's a systemic disease that affects bones and CNS and also heart. It can lead to heart failure as well, too. Case 7 is a case of mine, a 59-year-old man, history of obesity, hypertension, presented with abdominal pain again. And then periabdominal tenderness, or periumbilical moderate tenderness in the exam. Labs again, elevated ESR and CRP. And then what we extensive workup was negative. CT, very similar to the previous cases. Again, abdominal aorta is wall is very thickened right there. So because all the workup came back negative, we call it idiopathic inflammatory aortitis. And he was treated really successfully with steroids and methotrexate that were actually tapered down over time. And then his abdominal aorta has improved significantly 3 months later, and he's off treatment right now, and he's doing well. The last case that we have, and I put the last case because it was the worst case experience that we have, unfortunately, and it had an unfortunate outcome. 79-year-old male, history of rheumatoid arthritis. I want you to pay attention. Diabetes, hypertension, hyperlipidemia, came with abdominal pain and back pain. So he's already on infliximab and methotrexate for the rheumatoid arthritis. He's being immunosuppressed. I'm giving you the kind of giving you the hints for the diagnosis. And he has abdominal tenderness, back tenderness, leukocytosis, elevated ESR and CRP, blood cultures negative, lumbar MRI is negative because we were looking for infection, right? This patient has been immunosuppressed for a while. His urine culture was positive for MSSA, but the blood cultures were negative. And this is his CT angiogram. What you actually notice in the CT right here is not like very similar to the previous ones that he has circumferential. It's not circumferential wall thickening. It's like involving this area. There's also atherosclerotic calcified plaques around the aortic wall. So is this inflammatory because of rheumatoid arthritis, or is this infectious because of that UTI, or there's a little bit of contained rupture because of the atherosclerotic disease? So the patient, we've monitored the patient very carefully, and ID recommended to treat UTI, and we kind of put him on steroids, kept him on immunosuppressive, and we wanted to see him very soon, so we brought him back actually 4 weeks later, 1 month later, and his symptoms improved, but his ESR and CRP continued to be elevated. His cultures, again, we're still looking for infectious processes, still negative. And then look at the aorta this time. So it's kind of more suspicious of maybe now is it also already plaque right here? What is going on? This is a big change in 4 weeks. And then so the plan is, well, I talked to the Dr. Lesser and talked to my vascular surgery colleagues. What should we do? I think we should just add a statin, really monitor carefully because there was no real indication for a rupture at this point. And I wanted to bring him back 2 weeks later. Unfortunately, he presented 4 days later. And look at it right now here. It's very ill kind of looking wall thickening, and this is kind of a rupture now of the aorta. And now blood cultures came back positive from MSSA. So this is an infectious aortitis. So that was kind of a lesson learned that although the patient was on antibiotic anyways, but unfortunately the patient didn't make it. So infectious aortitis, this is a really bad diagnosis. Rare patients usually present with leukocytosis, which the other diseases do. Procalcitonin can be elevated. Patients would have history of recent infection, like this patient did. Positive blood cultures, not always. So 50 to 75% patients would have worsened symptoms on immunosuppression, like our patient did. And the wall thickening will be asymmetric, not circumferential, like we did see in the previous patient. So this is a paper that we published in our experience. I'm just going to go quick on this given the time because I want to finish the slide deck. We actually look at 15 patients with aortitis in our practice, between 2000 and 2016. And then we had 15 cases, eight cases with Takayasu, 5 cases with inflammatory idiopathic aortitis, and 2 cases with giant cell arteritis. We're talking about aortitis. And then the age, mean age is 51, and usually patients are younger with Takayasu versus inflammatory versus giant cell arteritis. Most of these patients are female, except those patients with inflammatory idiopathic aortitis. They are more kind of males. The sample size is low, I understand. Tobacco abuse was kind of prevalent in these patients. Most involvement is thoracic and thoracoabdominal. Except for the idiopathic aortitis. Usually, all the cases are males. These patients, all of them, they receive steroids and immunosuppression, some of them. And 5 patients had to undergo surgery and intervention for different presentations. There are a patient that had coronary artery bypass, grafting for severe left main coronary artery stenosis, and so forth. The main message here that all of these patients had successful outcomes, especially when their disease was under control with some minor complications related to the procedure. So again, more prevalent in females, except for the idiopathic aortitis that was more prevalent in males. Their smoking history was kind of prevalent. All idiopathic cases involved the abdominal aorta, and then patients with Takayasu presented with stenosis. And all patients actually received medical therapy, and 1/3 received surgical intervention or revascularization with 67% improved case activity. How do we work up these patients in our practice? So when these cases come to our practice, we get called the vascular surgery, vascular medicine. We get called to kind of have a multidisciplinary approach. So if there is a suspected case of aortitis based on the history and clinical presentation, I do send blood work for CBC, ESR, CRP. I look for ANCA, IgG4, C434, C3, C4, and so forth. And also I get blood culture, and if there is a possibility of obtaining a tissue biopsy, that would be great. Unfortunately, most of the time, it's hard to obtain a biopsy of a fragile inflamed aorta, so that's not usually a good idea. So we try to do it when we can. And then and also we look at images, ultrasound. Now we try to do that more often with GCAs, as we talked about that, CT angio, MRA, PET scan, and when we funnel the diagnosis to either infectious aortitis or inflammatory aortitis. For inflammatory aortitis, we kind of try to refer these patients to us. I kind of take over these cases as long as they don't have indication for vascular surgery, and we follow with vascular surgeons as well, hand to hand, to kind of help each other to kind of manage these patients. And the treatment is based on the underlying etiology. And if they require surgical or revascularization, I make sure that the patients are stable before my vascular surgeon colleagues operate on these patients. So noticing the difference, what I mean by this, that most of these patients present very similarly, right? So the symptoms are similar, the lab findings are similar, the imaging are similar, as you could see from this slide. Look, so this is the kind of 6 cases out of the 8 cases that we presented. Most of their CTs were very similar, right? Wall thickening in the aorta, inflamed aorta, and elevated ESR and CRP. So what are the key findings to indicate underlying etiology? So for GCA, look for older females. Females never get older, right? Just kidding, saying like, females 50 years and older. With headache, elevated markers, PMR, temporal artery biopsy, Takayasu females who are less than 40, blood pressure difference, poor pulses, imaging findings of stenosis. IgG4, it's a systemic disease with elevated IgG4, with imaging showing periaortitis, sausage-shaped pancreatitis, and you see that pathology of the findings that we talked about. In terms of periaortitis, that's kind of usually there is a retroperitoneal involvement with ureter obstruction or aortitis, and you confirm that with findings of fibrosis and inflammation. Erdheim-Chester disease, which is non-Langerhans, cell histocytosis, that you see periadventitial infiltrates with positive BRAF V6 600E in 50% of the patients, and your imaging showed hairy kidney-encoded aorta. And if you do all the workup and you don't find the underlying cause, we call that idiopathic inflammatory aortitis. So I want you to read this through. I know it's kind of a little interesting, and I want you to see who can tell me who said this. Okay, there are known knowns. There are things that we know that we know. There are known unknowns. That's to say there are things that we know we don't know, but there are also unknown unknowns. Anybody knows who said this? That's correct. Great, yeah. So he said that, it's the times of, when they faced him and said, well, you said that Iraq has whatever. In any rate, so I think that's kind of, I took this analogy for the aortitis. There's still a lot of unknowns for aortitis, right? And we always scratch our heads when we see these cases. In conclusion, aortitis, it could be inflammatory, infectious, neoplastic, idiopathic, very rare disorders. More research is needed to characterize and classify these disorders. Differential diagnosis, as I just alluded through this presentation, it could be very difficult and requires multidisciplinary approach, including vascular surgeons, vascular medicine, sometimes cardiologists, rheumatologists. And determining the disease activity could be very challenging. And actually, Dr. Stephenson and I, we had a recent case, a middle-aged man that came down with acute renal failure, mesenteric ischemia, and his aortic wall was very thickened, and mesenteric vessels were thickened, renal arteries were thickened, but his inflammatory markers were normal. PET scan was normal, so we decided to wait, but then he came down with acute renal failure. And then so Dr. Stephenson actually placed stents in both renal arteries, and the patient is doing great, and patient actually apparently had an active disease, and now we have him on steroids, his symptoms are improving. So this could be very challenging. So it's good to have a teamwork between the vascular surgeons and the vascular medicine and the rest of the teams. And then management includes steroids and steroid-sparing agents. Again, when you prescribe steroids, think about these elders being on steroids. That's not a good idea, or for a long term. Revascularization, when disease is inactive, there is an interest in increased use of endovascular approach. Like I shared a few cases, one case with Dr. Manunga, he also operated on other cases, and patients are doing great. So I think there is more interest in an endovascular approach. This actually topic, in 1 hour, we can talk about surgical approaches. Maybe that would be a different grand round that could be presented by my vascular surgeon colleagues. I tried to focus on, the challenges making these diagnoses and the treatment. This is the sunset in Gaza in one of our medical missions, and I hope the sun will rise in Gaza soon. I'd like to stop here and take questions, and I think I left some 5 minutes for the Q&A section. Thank you so much. Dr. Stephenson.
So we sort of have 2 classic large vessel vasculitis, Takayasu's and giant cell, but you just showed that there's even like 2 different subgroups in each. Do we need more diagnoses, particularly now that we have actually more than just steroids to give these patients?
Yeah, so the question, from Dr. Stephenson is, we kind of, the main thoughts in the past that we only had GC and Takayasu that hard to differentiate in between. So when I approach these patients, I do have in mind that this could be different than just GC and Takayasu. So I do actually the workup, as I just mentioned earlier, I do look at IgG4 levels, and I also look for other systemic vasculitis like Cogan and others, and I look for secondary autoimmune diseases. Does the patient have lupus, rheumatoid arthritis? So try to nail it down. And as I said, we cannot nail it down to a specific diagnosis, but most of these patients, if you're sure that it's not infectious, usually my approach is to start patients on steroids when I'm sure, almost sure, that there is no infection. And then I bring them back. But if I nail it down to Takayasu, then I would do methotrexate. If I nail it down to GCA and they meet the criteria for that, I add tocilizumab. And then I follow them. So these patients come back and see me usually within 4 weeks. I don't wait more than 4 weeks because I have to start thinking about tapering down the prednisone within the first four weeks. So I do bring them back in 4 weeks if I still have suspicion of different diagnosis or not. I still bring them back in 4 weeks and follow them. But to your point, yes, I kind of think about all these different diagnoses when we first meet these patients and try to discuss with other colleagues. Sometimes I have to call my rheumatology colleagues and have their input as well too.
Do you think there's a role though for, like, so temporal arteritis behaves differently than giant cell arteritis, temporal arteritis, so,
Yeah.
like, should we have we need more large vessel more diagnoses basically, because these are sort of different clinical subtypes.
Yes. So the question is, how do we really do about cranial versus large vessel GCA? All patients that come with a questionable GCA from a rheumatology or outside center do get the CT angio. I like CT more than MR. Some people fight with MRA is better. So I kind of feel comfortable with our slices. They're very thin slices, and I do actually run these tests to kind of see if there's a large vessel involvement. So I really need to know, because not only I want to know because they behave differently and the large vessels are more kind of aggressive and affect younger patient, but also I want to follow up these patients. If the patient has really significant wall thickening in the aorta, I want to know what happened in a month or two, because I want to follow the disease improvement. So yes, to your point, I do actually get images to kind of rule out large or cranial. And now, as I mentioned, Brian, our vascular lab, now has criteria. We have agreed on criteria to diagnose for the diagnosis and also follow up for GC to look at the wall thickness. There are criteria that we put together for GC. It's non-invasive, and now it's kind of more really adopted by the American College of Rheumatology. Yes. Oh, Dr. Sharkey.
What's the natural history of aortic aneurysm in these inflammatory diseases?
Okay, very good question. Dr. Sharkey asked, what is the natural history of inflammatory aneurysms? They're really kind of more progressive, and patients with aneurysm presentation with inflammation has actually higher mortality and higher morbidity. So we really kind of tend to follow these patients closer and more frequent than just the non-inflammatory aneurysms, because they could actually progress so fast if they have active disease. And then we know that inflammatory aneurysms can also present years after the initial treatment, because I don't want you to think that, patient is stable, GCA, come back as needed. Nope. You really have to look into these patients, because I have a colleague from Mayo that treated patient with the GCA, and then 5 years later, she came with ruptured thoracic aortic aneurysm when the previous CT was normal. So they can progress so fast, these patients, if you don't have really control over their disease. Yeah, yes, for sure. Yes, please.
Dr. Skeik, thank you so much for your time this morning. We do have one virtual question that comes from Dr. Lesser. He says, Nedaa, thank you for the great talk. And the question is, if you do not see marked lessening of inflammation on the target organ with imaging, do you continue or increase therapy regardless of serologic markers?
Okay, a very good question. Sometimes imaging findings could really lag. So that's why I don't really, or I hope usually to see a real improvement within 4 weeks, but sometimes we don't see that improvement within 4 weeks with Takayasu. But actually with the CT with wall thickening, sometimes we see chronic sequela, so you don't see significant wall thickenings improvement. So it's based on the case. So I give it usually 4-6 weeks to kind of say, hey, it improved or not. So Unfortunately, sometimes patients don't show improvement on the images, but yet their inflammatory markers are better, and their clinical presentation is better. Their abdominal pain is better, the constitutional symptoms or systemic symptoms are better. So I still consider taper. I do slow taper, and I still bring them back in 3 months usually, and do another image. And if they don't improve at all, I question the diagnosis. So am I missing anything? Especially if their labs also don't improve, and their clinical presentation doesn't improve, then I question the diagnosis. But there are cases that they have chronic wall thickness, fibrosis, especially with periaortitis and or Takayasu, that they develop fibrotic tissue around the aorta that's not expected to improve. And usually I try to use PET scan. If the PET scan is kind of negative, then I kind of assume that the disease is inactive. Very good question. All right. Well, thank you so much. If you have a patient with aortitis, don't think about just send them to me.